All right. Well, thanks, Jerry. I appreciate the opportunity to moderate the debate tonight. These have been very, very exciting over the last year, and I don't think there's any end in sight, and that's a wonderful thing for education. Forearm fractures, and particularly those that go bad as non-unions, are an exciting topic. Um, to be honest, when one comes into my office, I'm usually a little more excited than when I see a slack wrist or a tennis elbow. It's just, they're fun to see and fun to do. One of my mentors, Jesse Jupiter, made this historical paper in the Journal of Hand Surgery, which is a fun read, and it shows this ulna non-union treated with an aluminum plate, if you can believe that, and some screws and a bone graft. And of course, that was a long time ago, and the goal tonight is to debate really what we should do for this sort of problem in the year 2021. Now, before we dive into the nuances of forearm non-unions with our fellows, I want to say a couple things about forearm fractures in general. The first, of course, is that we fix them. We like to fix them, and we need to fix them because if we don't, patients lose their forearm function. And even the smallest amount of angulation can cause that to happen, as we know from cadaver studies and our own practices. And maybe one of the reasons we really like to fix them is the anatomy is pretty cool. We often end up approaching the radius from the Henry interval, so to speak, and there's a lot to see and a lot to do in this area, but the structures are pretty big, and as attendings, we're happy to pass these cases off and let the fellows and residents explore that interesting territory. Now, I've been fixing these for about 15 years now in practice, and the fellows teach me quite a bit every year about all sorts of topics. So before they educate us tonight, I want to give them just 4 pearls for going into practice when they see forearm fractures. And they already know a lot, they know the basics, but I just want to point out 4 things that maybe I underappreciated early on in my career. The first is you need to protect the region of the PRUJ. So not just the joint itself, but the general proximal part where the radius and ulna are quite close to one another. So here's a person with an olecranon fracture. I fixed it under a block, put some pins in. The patient was wide awake. She was pregnant. And I didn't check rotation close enough. And what do you know? She had trouble pronating and supinating just because I didn't respect the fact that the radius and ulna are real close to one another. And I ultimately took a pin out, and you can see where the bicipital tuberosity was eroded, and the patient immediately had full forearm rotation after taking a pin out. And that sort of problem you might encounter when you're fixing the radius, the radial shaft when it's a proximal fracture. So this is a 16-year-old, very small, just skeletally mature female, and the radius fracture is fairly proximal. I fixed it in the standard way, compression plating, and she had trouble with pronation as well. And what do you know? My plate is sitting right up on the bicipital tuberosity, and every time she tried to pronate, that plate was coming very, very close, if not impinging upon the ulna. So anatomic fracture fixation, everything healed beautifully, but the result was compromised until that plate was taken out. Don't underappreciate how close the radius and ulna are to one another proximally. That's why we get synostosis with some of the techniques we do for biceps. The second pearl I give the fellows is know the Thompson, right? So we know the Henry, we do it all the time, everybody's comfortable with it, but some fractures are more amenable to going dorsal, like this one, which was open dorsally and comminuted proximally. So the fellows are comfortable with going dorsal on the distal radius and approaching the radial head and neck, but the interval in between with all the muscle overlying the supinator and the PIN is a bit of tiger country. And for the fellows who haven't gone to the lab and just done this approach again and again, I would recommend they practice. And that's what we did here. This case also illustrates the third pearl I'd give to the fellows, and that is check the DRUJ. It's something that we tell them all the time with distal radius fractures and with Galeazzi injuries, but even a both bone forearm can have a DRUJ problem. And you might consider this a Galeazzi, but whatever you consider this pattern, this patient had an ulna styloid injury and was not stable at the DRUJ even after radial fixation. So we temporarily pinned it, and that afforded stability long enough for healing. So respect the DRUJ. And then the last pearl I give the fellows before they share their wisdom with us is respect the ulna. So in residency, we learn to respect the radius. It's the complicated bone. It's the bone with a bow. It's the bone with the tuberosity, et cetera, et cetera. The ulna bone is just a straight, immobile bone, and we sometimes underappreciate it, but the ulna is subcutaneous. It's prone to infection. Tissue can break down over the ulna, and even the ulna can be malrotated. So this is a gentleman that came to me because he couldn't pronate. He could supinate 0 to 90 degrees, but had zero pronation after he had an ulna fracture fixed. His treating surgeon had removed the plate, but his motion had not improved. And you can see on this true AP of the wrist, the right injured wrist just doesn't look right compared to the left. And again, we know that the radial styloid and the bicipital tuberosity are about 180 degrees apart from one another. And we're good to tell our fellows about that and our residents about that. But sometimes we maybe understate the fact that the ulna styloid really needs to be exactly in line with the humerus and the tip of the olecranon. So in this gentleman, you can see here's his humerus, tip of the olecranon, and then over here, the ulna styloid's pointing the wrong way by about 70 degrees. So we took him to the OR, osteotomized the ulna, rotated it back into good position, and we're able to get his pronation back 0 to 90. Now, we did have to do a capsulectomy at the DRUJ to restore his supination, but he ultimately ended up with full motion. So another point you can take away from a case like this is always check rotation on the table with the elbow flexed 90 degrees before you close up and leave. All right. So without further ado, tonight's forearm non-unions. The problem isn't that common, but when it happens, it can be a big deal. And the experts tell us it's either stability or biology or both. And often that biology problem is a soft tissue defect and or an infection. And we don't want to run into this situation. Dr. Dyer probably recognizes this face all too much, but he was a frequent flyer there for a while with a forearm problem. And these problems can be tough to treat. You know, we get labs, we do washouts, we put them on 6 weeks of IV antibiotics, and then we go back in. And what we do when we go back in is what we're going to figure out tonight. So Jerry said it was a cage match. I'm going to make it a dodgeball. We have 4 teams. We've got the Average Joes, the Purple Cobras, the Lumberjacks, and Skills That Kills. So first we have Ronnie Brown, fellow at the University of Washington. He's mentored by Stephen Kennedy, and they may be the Average Joes, but they're certainly not an average team. The rumor is that they see more forearm fractures in a week than most of us see in a month. So we look forward to seeing what they've got to say. Team number 2, this is Avi Goodman at the Mass General, a fellow, and he's mentored by one of my former residents, George Dyer, who's now surpassed me in every way. And they're going to give us the venom of growth factors, and they're all too cool. Just the name of their surgery, the Masquelet technique, speaks for itself. Third team are the Lumberjacks. This is Lee DiPrinzio, fellow at Duke, initially mentored by Mark Richard, who couldn't join us. So Suhail Matani stepping in his place. And these Lumberjacks are cutting out fibulas left and right down at Duke and are going to tell us how all their cutting is good for the environment. And then lastly, the home team tonight is our fellow here at Curtis, Joe Catapano, and he is mentored by James Higgins, and they're going to tell us how their microsurgical skills can give us maybe the best macro surgical result. So with those introductions, why don't we start with the Average Joes, Ronnie Brown.
Yeah, great. All right, thank you. As Dr. Forthman mentioned, my name is Ronnie Brown. I'm a fellow at the University of Washington. I'm lucky to have Dr. Kennedy mentoring me for this debate, and I'm sure it's going to be a fun experience for all. So thanks everyone for your attention and your participation. I'm going to prove tonight, once and for all, that bone graft and compression plating is all you need. So listen closely to my talk. That's all you'll need to hear. So we'll start with the case. It's September, and for all the fellows, you've settled into your new role as an attending, and this gentleman walks into your clinic. He's a 28-year-old right-hand dominant male. He sustained a gunshot wound to his right upper extremity 11 months ago. He had an open fracture of the proximal radius, was treated with open reduction and an X-fix application at an outside hospital, which has only recently been removed. And his case is complicated by radial nerve palsy. He has no signs of neurologic recovery. He's a former smoker. He quit about 6 months ago. He has limited wrist range of motion, no active pronosupination. And as you can see here, he has an atrophic non-union of the proximal radius. He's got segmental bone loss, radial shortening. He has DRUJ subluxation. And so we have to ask ourselves a couple questions. How would we treat this patient? What are his options and what's the best option for him? Is there any additional workup we need? And a question I've been asking myself more and more recently is, if this was me, what treatment would I be opting for? So if you're familiar with the complete cinematic works of Pierce Brosnan like I am, then you've probably seen his 2012 blockbuster Bone Graft, and compression plating is all you need. And if so, you're set. But for those of you who haven't seen it, if you're not familiar, we can dive a little deeper into this topic. Forearm nonunion poses a substantial reconstructive challenge for hand and upper extremity surgeons. And as Dr. Forthman mentioned, it does so for several reasons. The forearm operates as a functional unit consisting of the radius, the ulna, the DRUJ, PRUJ, and it's a unique bony relationship in the human body. It's been likened to a ring. The radius rotates around the ulna, and that's what allows us to position our hand precisely in space to do what we need to do. And you know, the radius and ulna often, or it also, serves as origin for several muscles of the forearm. So failure to restore these relationships, especially in a non-union, can lead to substantial functional defects. And this can result in a greater reduction in quality of life than non-unions elsewhere in the body. Luckily, it's relatively rare. When they do occur, they tend to be associated with infections and soft tissue loss. The majority are atrophic with segmental defects and often osteoporotic fragments on imaging. And the pathophysiology is similar to non-unions elsewhere. As was already mentioned, it's related to a failure of biology and or a failure of stability. Failure of biology is kind of akin to a failure of the typical bone forming process. It occurs through these well-defined steps we're all familiar with. And as we know, fracture healing, it requires osteoprogenitor cells, growth factors, and connective tissue matrix. And so a lack of these components or an interruption in the process will impede fracture healing and potentially result in a non-union. And more recently, mechanical stability, or a lack thereof, has been more widely regarded for its contribution to non-union formation. The mechanical environment at the site of a fracture has a profound effect on the healing and the callus formation. Without mechanical stability, like the inadequate plate and screw construct you see here, granulation tissue and fibrosis can develop, and then we're left with a non-union. Now, after we diagnose and address the potential causes of a forearm non-union, we need to select the treatment. This is a big decision, and of course, this is what we're here to debate. And the debate can get pretty vicious. Now, I know we were a cage match and then a dodgeball game, but I would like to propose that this debate is more like Game of Thrones. Hopefully some of you are familiar with. And since I'm going first, I'll set the stage. You'll hear tonight about the Masquelet's induced membrane technique. It's a clever and cunning solution to forearm non-unions, but I think it might fall quite short in some regards. The procedure it's variable. Outcomes can be dictated by surgeon preference or patient conditions. And the technique itself often needs to be repeated. Initial success rates only approach 86% in adults and 60% in children. So the success rates are really dwarfed by other techniques. And we still don't completely understand the biology or the physical mechanisms by which this works. So of course, the vascularized fibula, it's a righteous alternative. It's dependable. It's often referred to as a workhorse on the reconstructive ladder. It can be pretty hard to kill. And I admit I want to support this one. I want to root for it. I think it's a great option. But vascularized bone grafting is technically demanding. It requires advanced skills and resources like a microscope, high-powered loops, and they're often longer surgical procedures and may require a hospital stay. And these vascularized procedures have associated donor morbidity. So might not be the best option. And while it may theoretically have biological advantages being vascularized, we'll see later that these advantages have yet to be as evidenced in the literature as we may be led to believe. Then there's the vascularized MFC. It's new, it's shiny, so hot right now. It could be, I suppose, the solution to our non-union sorrows. It boasts less donor site morbidity than its fibula counterpart, but it's still a vascularized bone graft. These two are basically related. So I don't know if that's going to be a good option. And maybe we're just overcomplicating the situation by bringing another contender into the game. So instead, I offer you that non-vascularized bone graft, and compression plating is a real hero here. It's not fancy. It's certainly not flashy. In fact, it's maybe a little boring and anticlimactic, but it works. And so as we move forward, I want you to keep in mind it's probably not the solution you want, but I think it's the solution you need. So bone graft and compression plating, by its very definition, addresses the pathophysiology of a non-union. The graft addresses the biology, and the plating addresses the stability. Bone grafting has been a well-known and reliable procedure since the early 1920s, and it's something we're constantly refining. Non-vascularized bone grafts are readily available, and they come with viable progenitor cells, matrix proteins, and bony matrices. So it's got osteogenic and osteoinductive and osteoconductive properties to support healing and graft incorporation. And the mechanical environment in the graft site is also going to have a profound effect on the revascularization and the callus formation, as we mentioned. These principles of biology and stability make up the diamond concept. And this really describes the successful components of bone graft healing. And these principles have withstood the test of time. There are many studies supporting the efficacy of this technique. It's become the mainstay of treatment for forearm non-unions. Nicol first described the use of iliac crest bone graft and plate fixation for non-union in 1956. And in this series, he had 27 upper and lower extremity non-unions, 14 were in the forearm, and all achieved union at an average of 14 weeks. And he described in this paper some bone gaps up to 3.5 inches. He also stressed here the importance of both biology and stability. He referenced the superiority of autograft in regards to osteogenesis and osteoinduction. And he states that fixation, as an important first principle of grafting, must allow intimate and undisturbed contact between graft and host until union is achieved. Later, Dr. Ring and colleagues demonstrated a 100% union rate in their landmark paper using iliac crest cancellous graft and 3.5 millimeter plates. They had few complications here, and their patients saw substantial functional increase. Subsequent studies have demonstrated similarly impressive union rates. In this group here of 31 consecutive patients with forearm non-union, 97 demonstrated radiographic union at 3.5 months treated with iliac crest bone graft and compression plating. A large majority had good functional outcomes, and most returned to work. This paper here, Reagan et al. Later provided some outcome-oriented data in their 23 patients. All patients healed at 12 months, and 91% healed after only one procedure. And importantly, as you can see listed here, all patients demonstrated considerable improvement in their pain scores and their range of motion. Now, my colleagues will offer criticisms of our technique, and I think namely two. Firstly, they will tell you that autogenous grafting leads to donor morbidity, especially if we're talking about iliac crest grafting. And secondly, that non-vascularized bone graft should not be used for defects 6 centimeters or larger. The first criticism is a reasonable one and something we should consider. The The most common complication of these surgeries is related to the donor site morbidity. And the major and minor complications of especially iliac crest harvest have been well documented. However, the use of ipsilateral upper extremity donor sites like the distal radius and the olecranon, which was used in that top image there, these are associated with less morbidity and can avoid the use of general anesthetics. And newer techniques and instrumentation like the Reamer irrigator aspirator technique make harvesting large volume autografts possible with lower complication rates. And that second criticism you'll hear is the 6 centimeter rule, which is basically the 5-second rule of orthopedic surgery. As reconstructive surgeons, we reflexively state that non-vascularized bone grafts shouldn't be used for defects 6 centimeters or larger, but the truth is that this dogma isn't based on compelling scientific evidence. The systematic review you see here was investigating the origin of the 6 centimeter rule, and they found that the idea originated in 1983 with no objective evidence to support the claim. And this rule has proliferated through the literature. There's no definitive length-based comparisons between vascularized and non-vascularized bone grafts since then. And I agree that the performance of vascularized bone grafts and non-vascularized bone grafts will probably diverge as length increases, but that paper has yet to be published. So I think we have to ask ourselves, what really are the limitations of this technique, and should we be considering it more often than we are? So we'll go back to our patient. After weighing the pros and cons and informed discussion with the patient, we elected to proceed with iliac crest bone graft repair and plate fixation. After excision and debridement of this non-union, he was left with a 2.8 centimeter segmental defect. We used a distractor to bring the radius out to length, which corrected the ulnar positive variance. And then we harvested a 3 centimeter tricortical graft from his ipsilateral iliac crest and wedged it into the defect under some compression. He had stable fixation, which was achieved with a 2.7 millimeter Smith and Nephew Evo small frag locking plate. And on the table, he had 80 degrees of supination. He was mobilized in a long arm splint, followed by casting in slight supination for a total of 6 weeks, and then transitioned into a short arm splint for therapy. And he's continued to do well. He's had interval healing with significant improvement in the relationship between the distal radius and ulna, as you can see on the 6-week radiographs, and then a healed incorporated graft at 3 months. So in summary, non-vascularized bone grafting and compression plating, it remains the mainstay of treatment for forearm non-unions. It's not flashy, but it focuses on the root problems of a non-union, the biology and the stability, and has repeatedly demonstrated high success rates in the literature. The technique is straightforward to perform. It doesn't require specialized training or equipment and can be applied to almost any patient in any setting with relatively low cost and use of resources. And finally, with improving graft harvesting techniques, the morbidity remains low, and this technique doesn't burn any of your other reconstructive bridges in the process. I'd like to thank Dr. Kennedy for his mentorship, extending beyond this presentation, as well as my UW faculty and co-fellows. And these are my references. Thank you.
That was great, Ronnie. Excellent talk. Quite comprehensive, and it'll give us plenty of material to debate as we move along. So our second talk, I believe it's Avi Goodman, speaking as to the Masquelet technique with Dr. Dyer as his mentor.
Very good. Well, let me get going here. My name is Avi Goodman. I'm one of the hand surgery fellows at Brigham, and I'm here today to talk to you about Masquelet technique with growth factors galore for forearm non-union, and mentor is Dr. Dyer. So I'd also like to start off with a case here. So here we have a 62-year-old right-hand dominant lady who came in after tripping over a dog 2 weeks before. Of note, she also had a recent motor vehicle collision and had a left ulna ORIF 4 months ago that was performed by an outside surgeon. Her other medical history is not too significant. She doesn't smoke. She has a history of sarcoidosis, but is otherwise unremarkable. And her exam is what one would expect for a distal forearm fracture. The images here, though, are a little bit interesting. So we can see here that there's a distal radius fracture, as well as a distal ulna, what looks to be a non-union, as well as a potentially a peri-implant fracture. And the ulna had remained painful, and it's not clear that this had healed even 4 months from fixation. So with the distal radius fracture and with the painful ulnar non-union, she was indicated for a left ulnar removal of hardware and distal radius ORIF. And now 2 months later, so 2 months after the distal radius and 6 months after the ulna ORIF, she continued to have pain at her ulna without significant evidence of radiographic healing. So at this point, we discussed options with her and figured out what we could do. So to take a step back into forearm non-unions, like Ronnie was saying, we have to figure out what we're actually treating. Is it mechanical stability? Is it the fixation? Is it immobilization that was the issue the last time around, technical error, or is it this biology that we all hear so much about, the vascularity, metabolic response, or is it infection that can be somewhat of a combination of the two? So we have to aim to correct these underlying factors and optimize the patient before undergoing any kind of surgery. So our surgical options that we're talking about here, compression plating with iliac crest bone grafting, vascularized fibula, MFC flap. But the difference between the Masquelet technique is that it plays nicely with others. It's really an adjunct technique rather than a replacement. So it's a complement rather than a replacement, and because it can be combined with the others. So to dive into it a little bit more, the Masquelet technique of induced membrane formation can be combined with the others to help improve outcomes. And the theory is that by putting a cement spacer in, it can help form a thin collagen-heavy membrane around the cement spacer that's rich in growth factors as well as collagen. And if there are antibiotics in the cement, these can be used to help clear the infection if needed. Masquelet's original description of the technique did not include antibiotics, but it's become very common to include them. The indications for the Masquelet technique are aseptic or aseptic non-union. That includes epiphyseal, metaphyseal, or diaphyseal bone loss from trauma, tumor, or infection. And so notably, this, as we were talking about length, this can treat segmental defects up to 25 centimeters in the tibia or in the lower extremity. Obviously, we're probably not going to have that kind of length defect in the upper extremity, but it can be used successfully in these very, very large defects. The contraindications are also really important to think about. And most importantly is probably poor adherence, because you have to make a plan and a pact with the patient to be able to do stage surgery and have them be able to adhere to postoperative protocols. Also, massive tissue necrosis or poor overlying soft tissue envelope, as well as anything that might preclude good healing, such as radiation, steroid use, smoking, or malnutrition. So getting into the technique, first stage is to take out any hardware that's in there, debride back to healthy bleeding bone, and recapitulate the intramedullary canals by drilling. Then generally you do some sort of bony stabilization. This can either be with intramedullary fixation or plate and screw fixation, and then put some cement in. And like I said, oftentimes this is antibiotic cement. Give it 4 to 6 weeks to cook with or without IV antibiotics, and then move into stage 2. Stage 2, the first step is to incise the membrane. Then we remove the spacer and assess the bony stability. Next, we add bone graft. And this is certainly a matter of debate, but the bone graft that can be added could theoretically be allograft, usually is autograft, could be iliac crest grafting, it could be RIA, or it could be other sources, or it could even be a free vascularized graft, which is how this plays nicely with others. And then we close the membrane. And really the big advantage to this is that there's no microvascular surgery needed. So you don't need a microscope. It's generally a faster procedure, technically much less challenging. And the spacer provides mechanical support while the construct is healing. So this is not our patient, but it is a nice picture from a recent article describing Masquelet technique in forearms. And on the left here, we can see after debridement, there is the antibiotic spacer that's been placed in the radius and has been plated over the top. And this is the same patient, I believe 4 to 6 weeks later, after the spacers come out, and you can see this sort of grayish looking membrane that's under the plate. And after it's packed with bone graft, there are the x-rays which show a very nicely contained graft. An important thing to think about is the timing aspect of it. We know from basic science studies that the growth factors, type 1 collagen, and vascularity all peak at about a month and decline significantly thereafter. And so that's why the 4 to 6 weeks is what we've been targeting. So potential pitfalls, because it's packed with graft and does depend on creeping substitution through the graft, it can take a long time, like 3 to 18 months. And sometimes there's a need for repeat grafting or additional procedures. Sometimes, like with any surgery, the implant can loosen, the graft can fracture, or very occasionally the graft can resorb. There aren't many patients with this. Like was mentioned before, it's a newer technique, and so the longer term data isn't quite as much out there. So this systematic review last year looked at 12 studies, 70 patients, and 37 forms, and found a mean incidence of complications of 23%, which probably isn't so different from the mean incidence of complications when just looking at non-union surgery in general. But their conclusions were, unsurprisingly, were that most studies were low quality and they couldn't extract much data. So to look more at a more illustrative case series, this series looked at 9 patients who had segmental bony defects, about half from open fracture and half from non-union, with a 4.5 centimeter median bony defect. Their bone graft choice was 8 of 9 with RIA and 1 of 9 from crest bone graft, and 2/3 of these healed within 3 months. Another 2 of 9 healed within 6 months, and the last one healed within 12 months. And here it just takes a look at the individual fractures. We also see that 1 patient did require reoperation for plate fracture, and 4 of the 9 patients did have more than 1 spacer exchange, so either 2 or 3 spacer exchanges. So going back to our patient, again, we're here at this point, we're now 2 months status with the distal radius ORF and 6 months after the ulna ORF. She can continue to have the pain, and so at this time, we indicated her for Masquelet treatments. So with this, the surgery we did, the non-union site was entered again. There was a little bit of clear brownish fluid, but no evidence of gross infection. This tissue was sent, and nothing ended up coming up on micro. Some fibrous tissue was removed from the non-union site. The ulna was prepared, and a 4.5 millimeter drill was used both proximally and distally to open the interventional canal to clean it, but also to recreate the continuity between the canal as well as the area of non-union. Then we used a fixation device in the form of a 2 millimeter K-wire that was put in, and a antibiotic spacer was fashioned around that with an outer diameter of about 4.5 millimeters. And again, this gave some mechanical stability as well as providing antibiotic elution and providing a template for the membrane formation. So after coming back, she did well clinically. And then again, this is where it really goes into, you have to make a pact with the patient and make sure the patient's adherent. She was doing well. A CT scan was offered to take a look at the bony healing, but this was deferred. She unfortunately was a little bit lost to follow-up for a while, for the next 8 months or so. When she came back with no evidence of healing, it's still some pain. And so finally, we were able to convince her that to go back in and fix the problem once and for all, because it is a staged procedure. And because of the continued symptoms and the pin migration, she underwent the stage 2 of the Masquelet, which was the removal of hardware, removal of the cement spacer, and then open reduction internal fixation of the ulna with iliac crest bone grafting. Again, it can be a nice adjunct. So then about 6 months later, so it's 3 years after the original ulna ORIF, she fell again and got an x-ray, which diagnosed a 3rd metacarpal fracture. But luckily, we were able to see this x-ray, and it showed that there was some healing of her ulna, and differently from before, that she was finally asymptomatic. So in conclusion, the Masquelet technique is a very interesting, very useful adjunct to some of the other bone grafting techniques that can help to clear infection. It can help to create and optimize a pocket for the biology as well as mechanical stability, and it plays very nicely with others. So thank you for your attention. Here are my references, and I'll pass on to the next speaker.
Great, thanks, Avi. That was, again, another informative talk, and it's always great to see people present a case where there's been some sort of complication of their own, and yet they're confident enough in what they do to show it anyway. So thank you. The third talk is Lee DiPrinzio, fellow at Duke, mentored by Mark Richard, and tonight pinch hitting, or should I say dodgeballing or game of throning, Suhail Batani as his mentor. You can take it, Lee.
All right, thank you. I'm Lee DiPrinzio. I'm a hand fellow at Duke, and along with Dr. Matani, I'll be talking about free vascularized fibula grafting for forearm nonunions tonight. No disclosures. Fortunately, forearm nonunions are becoming more of a rare problem with modern fixation techniques, and as Dr. Forthman talked about, we usually group these in issues of stability or biology, and biology is really what we'll be harping on this evening. In terms of host biology, you should identify and treat modifiable risk factors as best you can. And then in terms of the local biology, the biggest factor that will probably be driving your idea for bone grafting and which type of bone graft to use will be the presence and size of the bony defect. But other factors such as the soft tissue envelope, the local blood supply will probably contribute to that. I think you can realize that even the bony defect in these two forearms might be the same, the local biology is much different. I myself am also a big movie fan, and while I enjoy the sordid works of Pierce Brosnan, I think everyone can remember this 1993 instant classic, Free Fibula. And while just like the procedure, it might not be something that I watch every day, it is the right movie for the right situation, and it holds a special place in my heart. It was first described in 1975 by Taylor and colleagues and has since been used for large bony defects throughout the body. In terms of its indications in forearm nonunions, I think that although this is a little dogmatic, as Ronnie said, it is still, the biggest factor is large bone defects after debridement greater than 6 centimeters. I think there are some distinct advantages to a vascularized graft, especially in a setting of multiply operated patient or persistent nonunion, as well as a patient who may have a chronic infection. The morphology of the free fibula is also ideally suited for forearm reconstruction. Not only is it a good size match for the radius and the ulna, but its makeup of a corticocancellous graft with the medullary canal is also a benefit. And the free fibula also provides a reliable skin flap, which can be very helpful for not only primary closures, but also to improve the local biology. Just a word about vascularized versus non-vascularized graft. The free fibula and other vascularized grafts carry the advantage that they do not undergo creeping substitution, which does cause a period of decreased stability as it's resorbed and neovascularized, whereas vascularized grafts are incorporated in whole and offers a little bit more early stability. Some contraindications, I think that in cases of a small bone loss, that some of the other bone grafting procedures we're talking about tonight will probably be better suited. In acute infections or untreated infections, likely a debridement and possibly a Masquelet would be the best primary treatment. And there are some donor site contraindications in terms of the vasculature of the lower extremity, but these should be able to be avoided with a good pulse exam. In terms of outcomes for free fibulas in the literature, there's only a handful of studies. Many of them are small with heterogeneous groups. So if you're looking at this from a bird's eye view, you're really looking at large defects with a time to union of about 3 to 4 months. The graft success is high, although non-union at either of the graft interfaces may occur. And the most common secondary procedure is a cancellous bone grafting procedure for that. In terms of the technique, I just want to go over this briefly as it's not something that we see every week, but this is the pedicle vascular graft from the perineal artery and its vena comitant. A lateral approach to the leg is performed, and the interval between the lateral compartment and the superficial posterior compartment is identified. That intermuscular septum will carry the skin perforators for your paddle, and these are most densely found in the between the middle and distal third of the fibula. After that skin paddle is designed, you continue to remove the lateral and anterior compartment musculature in this marbling technique where you leave the periosteal blood supply intact, and you incise the intermuscular septum and interosseous membrane. The pedicle is found both proximally, as shown here, and distally as well, through the posterior compartment. The bone cuts are made, and the pedicle is ligated distally first. And then the fibula and the pedicle are dissected in a distal to proximal manner, and the proximal pedicle is ligated finally. And here's a clinical photograph of the free fibular bone and skin paddle together. The anastomosis is done using microsurgical technique. Usually an end-to-end arterial repair is performed, although an end-to-side can be done if necessary. In terms of bony fixation, it's described many different ways in the literature, although we do prefer this image here of a large spanning plate with screws within the graft as well. Some takeaway pearls from the procedure. I think you should always consider taking the skin paddle. It will help with coverage and as well as monitoring the flap. It's important to close the leg after graft retrieval, as swelling can make this fairly difficult later in the case. For acute infections, I agree with Avi that a Masquelet technique is probably preferred. You can still perform a free fibula afterwards. It's important to preoperatively evaluate the vasculature both in the upper and lower extremity, but in the upper extremity, at least an Allen's test and a CTA if appropriate. And as stated, we prefer the spanning plate technique. Donor site morbidities must be recognized. In terms of long-term, it appears that pain in the ankle and sensory abnormalities do persist at about 10 to 12%. Motor weakness is transient, as well as some more infrequent morbidities, including leg pain, FHL contracture. We do place a syndesmotic screw in pediatric patients with years of growth left. In conclusion, I think the benefits of the free fibula is that it's a vascularized graft and it carries the benefits that come from that. It gives you an extremely large length compared to the other grafting procedures that we talk about tonight. It's an appropriate size match for the forearm and it has a reliable soft tissue paddle. Overall, I think it's a powerful tool to enhance the local biology of your non-union site. The downsides, it remains technically demanding. It may require secondary grafting procedures if it does not incorporate at both of the graft interfaces, and there are donor site morbidities that must be recognized. Just to finish it off, I'll go over a brief case presentation. A 19-year-old presented with a gunshot wound to the right forearm and a comminuted radial shaft fracture. Initially underwent a bridge plate fixation and a cement spacer was placed. They also underwent a split thickness skin graft at the initial admission. This was the injury film as well as the cement spacer film. And this was the skin graft that was placed. This was allowed to mature over the course of 3 months and he began therapy, at which time a free fibula was indicated. These are his immediate preoperative photographs, including the planned graft dissection and volar forearm approach. This was the radial artery, which was ligated the initial procedure, and the proximal portion was used for anastomosis in this case. This is the planned graft length and then the fibula graft, which was taken. And this is a clinical photograph, immediate postoperative, of the skin paddle over the radial forearm, as well as the fluoroscopy of the free fibula and that spanning plate. And his immediate postoperative radiographs. Over the course of 4 months, his graft incorporated, and he was ultimately cleared for full activity. This is an AP over that time. And a lateral over that time as well, and just some clinical photos. Here's my references, and I'd just like to thank mentors at Duke, especially Dr. Matani, for helping with this presentation tonight.
That's great, Lee. That's about the most delicate lumberjacking I've ever seen. Let's move on. Our final debate presentation will be with Joseph Catapano from Curtis, mentored by Jim Higgins.
All right, thank you very much for the opportunity to present today. I'm Joseph, one of the fellows at Curtis, and these slides come from Dr. Higgins, who is our Chief of Hand Surgery at the Curtis National Hand Center. So we've all heard a little bit about biology, stability, free vascularized tissue, Masquelet, and iliac crest bone grafting. And really, we're going to jump right into the free vascularized bone grafts to not recapitulate what we've already talked about. And there's several potential donor sites if you're thinking about free vascularized bone tissue: the fibula, the iliac crest, and then also composite flaps from the scapula, rib, lateral humerus, or radius. And while all of these exist, they're often limited by donor site morbidity and repositioning in the OR, which makes the fibula the workhorse for vascularized bone grafting for the forearm. And the fibula is the workhorse for good reason. It's versatile, familiar, provides a long length of cortical structural bone for reconstruction. But as with any donor site, as we've heard, there are some drawbacks. You have to sacrifice a major vessel to the lower leg. The aesthetic donor site is not ideal, and it's often tough to conceal. And it's a bit of an all or none donor site in that whether you need 1 or 25 centimeters, you're ultimately sacrificing the function of the fibula. So when a fibula seems like it may be a little too much bone, but you think vascularized bone is required for the biology or the fact that you need new, healthy, soft tissue, we'd propose the MFC as a good option as a donor site. The anatomy is reliable, it's conducive to transfer, easy to raise, and the donor site is well tolerated and hidden. So very briefly, as this can be reviewed elsewhere in the literature, the flap is harvested through a curvilinear incision over the medial leg. You approach the femur by elevating the vastus medialis, which allows you to visualize the descending geniculate artery and perforators to the skin. The pedicle reliably arises from either the DGA or superior medial geniculate artery in a small number of cases. You can then template the required bone over the medial femoral condyle and excise that bone with a periosteal sleeve for perfusion. So I'm going to jump right into some cases. I'm not sure how many people have seen MFCs in the past and show you some times that we've used it with good effect at our center. So the first case is a 44-year-old female with a non-union after corrective osteotomy. Cancellous bone grafting was used at that time. And these are her preoperative images, and you can see there's a reasonable bone defect there. And here are the CT images, coronally again showing the bone defect. One of our priorities here was to maintain her radial length as always and to avoid affecting her DRUJ. And given that she had already had a non-union, we elected to use vascularized bone graft. To measure the size of the defect, we placed a lamina spreader in the wound and took images of the DRJ serially to correct the length. We then fixed our distal plate to the fragment, reduced it to the shaft, after which we inserted an MFT into the cortical segment, and then typically what we'll do is keep that in place with a single locking cortical screw. So here's the image of the skin paddle and the clinical image after placement of the flap, and this has already been mentioned, but I did want to emphasize that it's important to illustrate that we usually do take this with a soft tissue paddle, even if there's no soft tissue defect. Because often when you put the flap in, you'll often find yourself with one, and this also helps keep pressure off the flap. And if the patient's unhappy with how it looks, it can always be excised at a future procedure. So here are images at 2 weeks, and you do have to be cognizant that because of the periosteal sleeve that the flap is raised on, you want to ensure that you don't plate on that side. So typically with radial defects, we'll place the periosteum radially and anastomose end to side into the radial artery. This is another case of a distal radius non-union following traumatic open fracture, and you can see the patient's fractured through their plate. These are the intraoperative images of the non-union site debridement. These images also once again demonstrate how we estimate the required bone graft size with the lamina spreader, and this defect measured about 5 centimeters. This picture serves to better appreciate how we inset the flap with the plate volar and the periosteal pedicle laying radial for anastomosis to the radial vessels, which we typically do end to side. And this prevents the plate from sitting on the pedicle. These are the immediate intraoperative images showing the plate placement with a single cortical screw into the flap. Here are her 6-month photos demonstrating incorporation of the bone graft. We've heard about infected non-unions as well, and this is an example of one of our patients with an infected non-union. The non-union was debrided, and we use a 2-stage reconstruction where we first place an antibiotic spacer, and then subsequently came back and reconstructed the defect with an MFT plate and a dorsal spanning plate to protect the reconstruction. Here are her images after removal of the spanning plate, again demonstrating healing of the bone flap. We've also used the MFC for larger defects, as that can be one of the criticisms, particularly of the ulna. This is a 47-year-old female with a large ulnar non-union after trauma. Once properly debrided, the defect measured just over 6 centimeters, and here you can see the dorsal plate. In this instance, we did take a longer segment of bone with skin measuring almost 7 centimeters, and here are her images at 8 weeks, 12 weeks, and finally almost 8 months showing incorporation. And these images highlight the point that the MFC is not dense cortical bone as the fibula is, so it likely doesn't provide the same structural support. And for that reason, we'll often use it to reconstruct either the ulna or the radius, but we'll avoid it for using it for humeral reconstruction where we do prefer the fibula. And here she is demonstrating good pronosupination after reconstructing respecting the PRUJ. And this is a common problem that you might face and everybody faces in practice, is the unfortunate non-union after ulnar shortening osteotomy. And again, we corrected this problem by thoroughly debriding the wound and reconstructing it with an MFC. And ultimately, these are her images after 9 years, again, demonstrating good bony incorporation. So while the non-structural bone of the MFT may not be ideal for structural support of the humerus, it does provide the ability to tailor to the defect. And this is a little off topic, but I did want to discuss the use of the MFC for defects of the wrist or the smaller bones of the hand. And so here we use an MFT to reconstruct osteomyelitis of the carpal bones. Here you can see the descending geniculate artery and the filigree of vessels coming off it, of which we template our MFC flap. Here's the flap being inset with a generous skin paddle. And finally, postoperative films at 3 weeks, 10 weeks, 10 months, and 5 years, again demonstrating excellent bone incorporation. And I think we're running out of time, so I don't really have time to delve into the literature, but I did want to mention that a lot of other groups have utilized the MFC flap with good effect. It is the new kid on the block, but a lot of people are using it, and the complications seem to be acceptable. It's also been compared to conventional iliac crest bone grafting, and while all sites did heal, it did heal in much quicker time, allowing patients to return to their function a little bit earlier. Now, unfortunately, as with all donor sites, there are risks and complications, as nothing is for free, and there are some specific complications related to the medial femoral condyle flap, and specifically that's limitation in activity secondary to their knee function, persistent numbness or paresthesias in that area. And there was one patient and one case report of a supracondylar femur fracture requiring open reduction internal fixation after a medial femoral condyle flap. So you certainly do have to remain cognizant of that. But this was a systematic review, including 203 patients. And so you can see there's still a low incidence of complications. And so that naturally asks the question, well, how much bone can you actually safely take from the medial femoral condyle? And this was a study out of our center that looked at a standard width and depth of 2 by 1 centimeters and lengths ranging from 3 centimeters to 24 centimeters. And while this was a biomechanical study, they did try to account for the differences in the in vivo and ex vivo differences. And they ultimately found that you could harvest quite a long flap without compromising the axial stability of the fibrin, and that was about as much as greater than 9 centimeters. So when do we use MFC at Curtis? And typically for atrophic non-union, when you think you may need vascularized bone graft because there's inadequate local biology to overcome the non-union. Intermediate defects of the forearm and wrist, as those defects become larger, we certainly do favor a fibula. But every flap does have its niche, and I think this flap is starting to establish one for forearm non-unions. And then, of course, if you have a compromised wound bed, so in the instance of radiation, trauma, when you have poor surrounding vascularized tissue to revascularize bone that's essentially dead as you put it in there, we would consider a vascularized bone graft with an MFC. And so I'd like to say thank you to Dr. Higgins, Dr. Forthman, and all my mentors at Curtis, and for the opportunity to participate tonight.
Wonderful, Joe. Thank you for that fourth outstanding presentation of the evening. I think what hit me or struck me most was how much overlap I saw in the presentations in terms of what techniques people used at various times. It's some of the debates you kind of walk away wondering whatever will I do, but I think we've answered some questions tonight. We've got about 10 or 15 minutes to drill down on some points, and I'm going to lead the discussion here. I'm going to share my screen and show some cases, and I'll try to call out some of the mentors. Unfortunately, Dr. Dyer stepped away, but anybody's certainly free to chime in. But I want to hit on some points or answer some questions that I still have, and we'll rely on the mentors to help us there. All right, so we're going to start. We'll start with a basic question. So this is a 55-year-old smoker. It's a nightstick style fracture, right? A diaphyseal ulna fracture, and it's put into a non-union generating short arm cast for 3 months. And what do you know? The middle picture shows that it hasn't healed. So she's put in a long arm cast for 3 months, and this is what it looks like. And the question I have, and I'm going to ask We'll ask Dr. Kennedy first. When you have a smoker, first of all, is that at all relevant in how you manage their fracture? And then in a more general perspective, is it true that we should treat all ulna shaft fractures non-operatively, or at least for the most part?
Well, I think that we should treat patients who are smokers differently. I think that there is an increased, significantly increased risk of non-union with smoking. There's evidence that even if you can convince them to reduce smoking or stop smoking, even if they continue to use nicotine, that can significantly improve their rates of bone healing. But ideally, if you can get them to quit nicotine completely, then you're going to improve their union. I don't do cotinine testing before surgery. I explain the reasoning behind it. Do my best to convince the patient to quit smoking. Usually they are amenable to doing that, and then I just have to trust that they've done it, and then I treat them like anybody else and proceed with surgery and give them the best that I can.
And then with the ulna fractures, should we be more aggressive with ulna fractures? Or is it okay to, as one of my former faculty said, put them all in an ACE wrap and say goodbye?
Well, I think the evidence for distal ulna fractures is actually pretty good. If the alignment is within acceptable parameters, there's a relatively high rate of union, and the technique of driving a K-wire or Snyman pin down the distal ulna can also be very effective. So you may not necessarily need to open all of the ulna fractures, but the location in the ulna is important, and I think this location of the diaphysis and the proximal diaphysis, especially with the there's a gap there now. I think you have to be aware, and you have to adapt and change. Any study where they look at patients who are treated with a non-operative protocol, there's always a potential for crossover. So just because you decide to start off by treating all of your amenable ulna fractures with closed treatment, you have to be ready to switch to an operative approach when it's necessary.
Okay. Well, we treated this at 6 months with autograft from the tibia and compression plating. But let's move on to something that's a little more challenging and more along the line of the situations we're talking about tonight. So this is a 40-year-old male, had a gunshot wound. The ulna was plated. By history, it got infected. The plate was removed, the infection eradicated, and he's now in our office complaining of pain, and he has these x-rays. And my question for Suhail, if you're there, is, does it matter that he has a history of infection, or does that not enter into your algorithm much if at this point it doesn't seem to be an issue?
Sometimes the answer is depends on whether you're in board collection or not. And thankfully I passed my boards a while ago. So, you definitely, it's warranted to do the workup from a laboratory test standpoint. And I think the most conservative approach in this setting would be to, consider doing an open biopsy and culture prior to planning your definitive fixation or intervention at that point. So that would be kind of the most conservative way to approach it. I think it is pretty reasonable as well in these settings to, when there's not quite such an elaborate bone gap, to culture and do definitive fixation and even grafting and mix in some voodoo vancomycin powder in your graft as well. That's probably the approach that I would take in that setting, is doing a crest graft. If the gap was reasonable, send some cultures and then treat through the healing process if they came back positive, and then remove the hardware at the end of your achieved union.
Mm-hmm. You bring up what I think is a challenging intraoperative scenario, and that is when you have a history of infection, but it's probably been cleared, and you get in there and it maybe looks a little bit suspicious, and you kind of wonder what to do. Should I debride it again and close, or should I debride it and fix it and then just place them on antibiotics for a while? And I think one principle that's often emphasized, at least in the trauma literature, is it is okay to fix fractures, even sometimes in the setting of what is a low-grade infection, so long as we can continue treating through the healing process. So let me follow up with Jim Higgins. Jim, you've got this patient now. We don't think he's infected. All evidence is that he's not. What's your surgery of choice for this sort of defect?
So I think all these questions, Chris, are also peppered by their social scenario, obviously, but I strongly am in favor of open biopsy and waiting for the results of the open biopsy, because it depends too on what your next card that you're going to throw is. If it's a free flap, wherever it is from the human body, that's a pretty big bullet to release from the chamber, and you don't want to be doing that with uncertainty in your bed. So I think if you're going to, and I know this is a little bit hazy, but if you're going to bone graft, then maybe you'd be a little bit more apt to say, hey, let's see what the intraoperative culture show a few days later after I bone graft this, and I'll treat it with antibiotics. But if you're discharging a fibula or an MFC, you want to make sure that counts. So, but to get back to your question, I would say that I would err on the side of treating this with a vascularized bone, although I loved all the presentations, Ronnie's and Avi's and Lee's tonight. And I think, as we said earlier, Masquelet is great, but it's an adjunct to the other three, really. And this would be maybe a time to do that if you were uncertain. When taking a case from the outside world, it's not your own case. Someone says, hey, they were treated, quote, completely. I like to hit the reset button and say, we're starting over. You know, it's got to do with the patient's job and their wage earning and all sorts of social scenario issues, but you want to make sure that you're given the full osteomyelitis treatment under your terms with your infectious disease specialist and reset the clock. But all you're asking me, Chris, is would I use vascularized bone or would I not? And I would use vascularized bone. This defect's small enough. I would use MFC. Now, one may say, what about the length of it? And I think Joseph did an awesome job talking about the length issue. If you're concerned about the length and the morbidity to the fibula or to the femur, I would urge you to consider just an on-lay cortical cancellous graft with buried cancellous bone underneath it. So it's really not important that you take a full thickness of the medial femoral condyle. You just take cortical cancellous potato chip, as people have ridiculously called that technique, onlay it, and then you can take tibial bone graft, iliac crest bone graft, whatever your cancellous bone graft is your favorite, and then onlay it. And that would alleviate your concerns about digging into the medial femur. But that's what I would do. I'd put an onlay on here and I'd probably put bone graft underneath it.
All right. Well, this is actually what you and I did about 10 years ago. You probably don't remember, but we fixed him with an MFC and he went on to heal. And Joe was, accurate to say that the MFC is not a particularly dense graft for those who are looking at fibulas. Any concern with how this graft looks at 7 years?
Yeah, totally. That's to me, right, Chris? I totally agree. These they don't start looking like the ulna or the radius. So don't wait. It's unicortical. It's not tricortical iliac crest. It's not a structural graft. You do need to rely on your hardware for a very long time. You'd be much more concerned about removing your hardware. I think Chris is probably considered with this guy who's got a plate that's running right over the electron. Removing that is much more concerning than removing a healed fibular flap and removing the hardware, because you're not going to gain, the words structural graft and non-structural graft are still pertinent, even in the world of microsurgery. So I think that this is never structurally relevant. And that's why there really isn't too much of a home for it in a lengthy defect or most humeral defects.
All right. I would follow up with that with Dr. Dyer. Unfortunately, I had to step aside, but Dr. Kennedy, is a cancellous graft put into a membrane or not even in a membrane going to look more dense 7 years later or not? What do you think?
I think it will. And when you first do it, it doesn't. but I think in the long term it will.
Okay. Well, one of my mentors sent me this message in an email, and it says diaphyseal forearm nonunions are the result of technical deficiencies or infection/complications if there's a well-vascularized soft tissue envelope, and no infection, cancellous graft and a plate will work. And so Dave has said that, and that's, you know, based on his experience with Jesse Jupiter, and this case has made its rounds at meetings of a Galeazzi that was infected and ultimately distracted and plated and treated, in fact, with this wave plate sort of technique. And the concept is put a wave in the plate, of course, so there's more room for graft. And this fracture went on to heal with a good result. And you know, another case here with a big defect treated with just some cancellous graft and presumably healing. And my question to you again, Steve, if you don't mind, let me fire at you one more time, is when you're grafting these, what's your go-to site now? Are you reamer irrigator aspirator, or is it still a tricortical sort of crest situation for you?
It really depends on the length, and for those lengths less than, say, 4 centimeters, then I'm using a iliac crest, or a distal radius or proximal ulna graft. I think you can use structural grafts from multiple different places. And then for the longer grafts, where I need a lot of bone material, then a reamer irrigator, or RIA.
Mm-hmm.
Yeah.
Okay. All right. So let me show a quick case where there's a suspicious delayed union, 62-year-old. We get into the OR and the radius is concerning for infection. It gets debrided and an intramedullary rod put in with some antibiotic-laden cement. And my question is, some would say, well, this is the ideal technique. It's the Masquelet technique. And others would say you can't cure infection if you have hardware around an area of previous, bacterial colonization. So, Suhail, do you have any concerns about putting a plate or an intramedullary rod at the site of an infection that you're treating with antibiotic cement?
I've done this several times, and I don't think so. I mean, I think that your eradication of infection is about appropriate initial debridement, and resecting bone that's not viable, and debriding the soft tissue that's grossly infected. And the antibiotic spacer is a drug delivery device, just like it's coded. And ultimately, you're treating with antibiotics and the spacer for the duration of time to eliminate that last 2% of bacteria that'll come back and get you, as opposed to being the primary one. So you just have to be obstinate about your initial debridement, and as kind of Dr. Higgins alluded to originally, you have to be conservative about your indications to go back and debride again. And many times in these settings, especially if somebody's sent to me as a secondary consultation, I'm talking about multiple debridements before even placing something like this in them, before and certainly before I'm ready to do my definitive fixation and bone grafting.
Well, as part of that serial debridement process, Suhail, is there a role for the stimulan beads? Those have become a little bit more popular recently amongst the traumatologists. Is there a role in your serial debridements for that sort of delivery system, or is cement still your preference each time?
The issue that I run into with stimulan is just the amount of fluid that it generates, and so having a draining wound ends up being problematic in that setting, and so I tend to put the stimulan in the wound that I'm more or less done with, and that I'm okay to put a drain in and kind of leave it be. And so I almost kind of use it a little bit more as a soft tissue management device than a bone defect management device. And so yeah, that's just been my caveat. I've seen it had a lot of fluid generated with it.
Mm-hmm. All right. I want to bring up this last case to wrap up the discussion for tonight, because we do have to respect everybody's time. Those of us on the East Coast are getting tired. So this is a radius that went on to a non-union and an infection and was treated with, pinning out the length, and it has a big defect. Gets taken back to the OR for this big defect. It measures, 5.5 centimeters. And I want to wrap up tonight. I want to drill down on, does size matter, right? So we've seen presentations where Masquelet or even cancellous graft have been used, at least case reports in large, long defects. This is 5.5 centimeters. It's bordering on 6. Is it true, like Mark Richards says in this paper, that once we hit 5, we need to be thinking fibula? And I'll first ask you, Jim.
Well, Chris, that number was generated a long time ago about vascularized versus non-vascularized bone grafting, and it was pretty arbitrary. And I think people have concluded that there are a lot of other biologic issues and speed issues and social issues appertaining to the patient and the health of the patient's lower limb, and whether or not they have 3-vessel limb, and whether or not they, what their age is. And there's a million issues. So I don't think size matters. But if you said to yourself, I'm not going to do Masquelet followed by bone grafting here, but I'm going to do Masquelet followed by some vascularized bone, which I think a lot of people would say, it's just an issue of like timing and how much of this person's life do they need to give up. And then you're really talking about fibula versus MFC. You could talk about iliac crest, but it's a pretty obscure and not often used harvest site. So I would say in this situation, this is long enough where you would say it's worth taking a fibula. It's a funny discussion, right? Because who says what's long enough to take a fibula? I think what you're really thinking is, do I need structural graft? And here we have another strut which is intact, and that's an important part of the algorithm that we haven't talked about. Like, is the other column intact? Having an intact ulna does give you time. It does give you confidence. Yet even at that, I would say in this situation, you'd be more comfortable putting a fibula in here because you've got a long corticocancellous strut. You could put a MFC in here. Were I to do that at this point in my career, and I'm a little bit worried after what you showed her earlier there, Chris, you're about to show that you and I did this about 10 years ago, and I put in this massive MFC. But what I would do now if I was to use an MFC would just be a corticocancellous wrap followed by massive cancellous grafting from the tibia. But you could very easily also do this with a fibula. So I think a lot of that discussion would be based on their lower extremity vascular exam. Are there pulses in the foot or not?
Mm-hmm. Thank you very much, Jim. And Steve, as a part of the Average Joe team, can you just do cancellous graft here, or iliac crest, or some combination thereof, or is this one that even in Seattle we get a vascularized graft technique?
Yeah, we have to debate these things for the purpose of this, but I think any of the above would be fine. I think a vascularized fibula would be good for this, and I think a RIA, a Masquelet technique with RIA would also be excellent.
All right. Well, thank you everyone for participating. These sessions are always wonderful, and of course the highlight is our fellow presentations, and they knocked it out of the park this time, just like they seem to do every month. Until June 10th, everybody be safe and take good care. Good night.
Nice job. Thank you very much, Chris.